Everyone. Hey everyone, we are going to talk about diarrhea today, acute diarrhea specifically, and this is in a resource-rich setting. So that just basically means usually in a developed country, but parts of a developed country may not be resource-rich. So there are parts of the U.S. that this may not be applicable to. This is, again, not a giant lecture for this module. There's definitely some important stuff. For just testing purposes, please focus on the medications as usual. So there's going to be a lot of slides in here that are going to be FYI and maybe beneficial for pathophysiology and ICM. So let's get into it. Introduction. It is unfortunately still a big issue. Diarrhea can be a killer, especially depending on what part of the world you're talking about. The good news is, or I guess the good thing for us is that here in the U.S., it is just more of a nuisance disease. It's not as life-threatening as it can be. But again, too, they use the language resource-rich setting. So, there are some pockets, unfortunately, here in the U.S. that are not considered to be resource-rich. And it still can be an issue and still can sometimes lead to hospitalization and can be complicated here. But for the most part, it is something that's more of a nuisance, but definitely something you guys will be seeing on your rotations and out in practice. Just go ahead and read through this introduction here. And then I like this algorithm too. It's the evaluation of acute diarrhea. Again, for testing purposes for me, this is an FYI slide. This may help with ICM and you're studying for that. But for me, it's just you can read through it. But don't stress about memorizing it or, me pulling specific test questions necessarily from here. This is just an FYI, again, slide just showing that there's some different guidelines you can use. Couple of the society here and the American College of Gastroenterology are a couple ones you can refer to. But all this stuff is from up to date from my presentation. Definitions here, just so everyone's on the same page, just go ahead and read through those. And more definitions here: acute, persistent, and chronic, and then invasive diarrhea or dysentery. Good definitions here. Go ahead and read through those. This may be beneficial for my course as far as for testing purposes. If I mention, if the patient in the question has acute or chronic or invasive or whatever, these are the definitions I'm referring to. So please note this. And then I believe this will also help you with ICM as far as defining what type of diarrhea your patient has, and on rotations and everything else too, right? Management. So, like I mentioned before, a lot of times it's just going to be a nuisance for your patient. So it's going to be symptom management. You will rarely go with antibiotics. That's going to be more severe, more of an inpatient setting. And we'll touch upon those here in a little bit. But for the main part, it's just going to be kind of symptom relief. So a big part of that is going to be fluid replacement. And this is for anybody who has diarrhea. So acute, chronic, etc. If the fluids are a big issue and a big reason why it's a killer, unfortunately, that the dehydration is something that can kill you, right? If you go without proper hydration, it can be lethal, unfortunately. So go ahead and read through this. So most of your patients, depending on their education background and stuff, they may know that they should have, some certain drinks, etc. There's definitely, depending on the culture of the patient, depending on their background, there's old wives' tales, the old farmers' remedies, etc. As far as what to drink, what to do, what to eat. And so those are usually pretty good to stick with, like having like soup broth is one that I come across, or Gatorade is another one. Those are usually not bad. And so just go ahead and read through this. It's like saltine crackers, plain bread. Those are some of the ones they're pretty commonly known. I'm hesitating here a little bit because it's going to definitely depend on your patient and their background. Don't ever assume a patient knows all this stuff, even if you feel like, everyone knows, to just, to modify your diet and make sure when you have diarrhea, and then to make sure you get enough fluids and fluid replacement. Don't ever assume that, but a lot of people do kind of have these home remedies and stuff and kind of know about them. There are commercially available products. They're called oral rehydration solutions, or the ORS. So they have those couple brand names here. Don't stress about memorizing these necessarily for my testing purposes, but I think it's good to go ahead and to know that they're out there. Go ahead and read through this. This is they have a specific osmolarity, specific content as far as glucose and electrolytes are concerned. And then this is a good table here. Again, don't worry about memorizing it for testing purposes for me, as far as I won't say, hey, what's in Pedialyte? How many, milliequivalents of sodium are in Pedialyte? That's not something I'll question you guys about, but it is good to know that these are commercially available ones on the top of the ORS, and then these are the commonly used. So these are the ones that you'll have patients come to you saying that they take Gatorade or they take ginger ale, chicken broth, and you can kind of see here, it's interesting that these have some of the good stuff in them. So some of these home remedies, some of these older remedies they're not bad, right? Unless there's some contraindication or something to taking this, or so like having chicken noodle soup, for example, when you're not feeling well and you have diarrhea or whatever, it's not necessarily a bad idea. It has some electrolytes you can see, and the osmolarity's similar, not exactly the same, but anyways, but you can also prescribe these. So Pedialyte prescriptions, we fill a lot of those. And they also are available over the counter as well. And the reason I said prescription is because sometimes with insurance or the patient's insurance maybe will require a prescription, or, Medicaid, Medicare may have requirements as far as they actually need to see a healthcare provider. But anyway, so yeah, FYI on this table, definitely I think, read through it and be familiar with it, and be familiar with the brand names. You do hear the brand names thrown around a lot, and you almost guaranteed going to see these. Like I'd bet money if I was a betting man, that you'd probably, Pedialyte's one you're going to hear on your pediatric rotation pretty frequently. Just go ahead and read through this too. Again, it's important. Same thing here too. More, things based on guidelines, but it is definitely something that these, the Pedialyte and, these products are superior to Gatorade and some of these other things. You would notice they are, they're manufactured to be kind of the best sort of combination of electrolytes, carbohydrates, etc., osmolality, etc. So that is going to be really, if the patient can go with those, and they do have, they're available and they have access to them, that is going to be your number one kind of first line to go with your patients. But anyways, just go ahead and look through this. Note here too, it's interesting that oral rehydration therapy is grossly underutilized, even here in the U.S. And then healthcare providers tend to overuse IV hydration. So that's something to be mindful of. I know as students, it's hard to kind of change the minds maybe of some of the practitioners, and then hospitals will have protocols and stuff. So you might not want to fight the good fight, but when you have your own, as a student, but when you have your own license and stuff, that is something to be mindful of, that, oral rehydration therapy is good. It can be effective. But anyway, so yeah, just go ahead and read through this as well. Dietary recommendations too. I mentioned that, a lot of patients will kind of already know about these things, but you just kind of think of like plain, unflavored, not spicy, just maybe some salt, plain stuff: crackers, bananas, soup, boiled vegetables, potatoes, noodles, rice, wheat, oat, just pretty plain, plain things, plain tasting foods. High fat should be avoided, and dairy products should be avoided, with the exception of yogurt, because yogurt actually has beneficial bacteria in it that it can actually help restore the gut flora. So and advise your patients to just stay away from high fat and then dairy products. And with the yogurt too, just to note here, unfortunately here in the US, some yogurt products do not have live active bacteria cultures in them. So you want to check the label on those. I don't know why they do that here, but anyways, it needs to be a yogurt with a live active culture. So you'll have to read the label on there. And then just too, as a general health, if anyone likes yogurt or is interested in, or if you guys make yogurt, my wife makes yogurt here at the house all the time. We have homemade yogurt. It's a great thing to eat, and it's great for your gut health overall. But definitely it's something for patient education, to read the label and make sure that they don't kill the bacteria in the yogurt, because that's, we've been eating it for thousands of years or whatever as humans, but it's important that they're live, active bacteria in their yogurt. Empiric antibiotic therapy, this is, not done all the time. I'd refer back to that algorithm definitely, but it's not recommended to do routinely. And you can actually have increased risk of a C. diff infection, let alone cost, let alone resistance. Overuse of antibiotics, is an issue we've talked about before with other things. Same thing with diarrhea. It's not something you just want to just go with right away. It is better to to try, with the dietary interventions that we already talked about, and then definitely fluid replacements, hugely important, and then some of these anti-motility agents, which we'll talk about here in a little bit. But the empiric antibiotic therapy is something you want to be mindful of, and be conservative with your antibiotic prescriptions when you're talking about. There are instances when you do need to use empiric antibiotics, so please definitely note these here. These are important here. And then also this algorithm, again, it'll show you, if you go through this, answer these yes or no questions, it'll show you in some of these gray boxes of when you do need to use antibiotic therapy. Oh, is that in there twice? Oh, okay. Sorry about that. Yeah, it was such a great slide. No, use it twice. One sec. So if you, again, follow the algorithm, it's indicated there's a good rationale to prescribe an antibiotic. You're going to want to start with the fluoroquinolone, specifically Cipro or Levo, ciprofloxacin or levofloxacin. Those are going to be your two first-line antibiotics to go to. And norfloxacin's not available in the US, so don't worry about that one. And then if a patient cannot tolerate it, or they're unable to take it, or an allergy, or they're not available, or if it's a fluoroquinolone resistance area, so there's, we're concerned about resistance, you can then go with a macrolide, so specifically azithromycin or erythromycin. So please put a star on this slide. I want you guys to know, first of all, know that you need to be conservative with it, and, again, follow the algorithm, make sure you have a proper rationale. This isn't going to be for all of your patients with acute diarrhea, but if they do, fluoroquinolone, Cipro, Levo, and then macrolide, azithromycin or erythromycin. So anyways, it's just showing too that this can also, so the other thing to note too, and please put a star by this too, for traveler's diarrhea, the fluoroquinolones are considered first line agents for those. And again, Cipro and Levo for the traveler's diarrhea. There are some specific circumstances that you may want to, that you don't want to go with the first line treatment, other than, like I said, if they're allergic, or so some specific instances, if you are concerned about C. diff, you'll hopefully remember that the that the fluoroquinolones don't hit the C. diff infection, so you'd want to prescribe something. If you are interested in killing the C. diff infection, you'd want to prescribe something like metronidazole, which is generic for Flagyl, or the oral vancomycin, so PO vancomycin. Same thing too with pregnant women. You're going to have to take into consideration what's going to be, beneficial for them. And if you suspect listeria, you want to make sure you get an antibiotic that has coverage for listeria. And then too, you need to think about if the person has potential, if you're concerned about cholera, then you need to go with another antibiotic choice. So so for testing purposes here, just to recap, just definitely put a star by here. And this is just for your, first line for most patients for acute diarrhea. It's going to be a fluoroquinolone and then macrolide. This is just showing that this slide too is also showing just kind of reiterating that it's not always going to be first line, or not always, the first thing to go to is antibiotics. So you guys can read through that. One of the things that is going to be first line for most of your patients is going to be an anti-motility agent. So you'll remember we've talked about loperamide before, which is the generic for Imodium. It is over the counter, but they also have prescription too. We have the dosing here. This is just more FYI. Don't necessarily worry about memorizing that for testing purposes. And this is going to be your first line if the patient does not have a high fever and is also if the stools are not bloody. So kind of on that same thing, you should not use these anti-motility agents if a person has dysentery. So you remember that definition from earlier. So that is something that you need to be more cautious with. And in those patients, you can maybe go with the bismuth subsalicylate. So hopefully, again, you'll remember that from previous lectures. That is the Pepto-Bismol. So that can be something that is good to use. But you do need to be concerned with, like I said before in previous lectures, it is a salicylate. So it's related to aspirin. So you need to be concerned with salicylate toxicity, and then also too with your pediatric population. So that, again, make sure you are not prescribing it because of the risk of Reye's syndrome. You're not prescribing it for patients who are under 12 years old. They are effective. The anti-motility agents are effective, but they do need to be used with caution. They can have some issues. So anyways, just be mindful of that and go and read through this. There's also the difenoxylate, excuse me, with atropine, which you hopefully remember from previous lectures, the Lamotil. This one, here's the dosing here on that one. Again, this is going to be more second line. If you're interested, if the patient qualifies and you're interested in using an anti-motility agent, your first line is going to be loperamide, and then your second line is going to be the difenoxylate. One is because it's an opiate across the blood-brain barrier. It has the atropine with it, so you have to be concerned about the cholinergic side effects, right? So that's something, and it's also prescription only, and it's so probably maybe a little expensive. It's a controlled substance, etc. So yeah, of the anti-motility agents, loperamide is going to be your first line, and then you're going to go with a difenoxylate with atropine. And then please, go ahead and read through all this rest of this stuff here. You can also go with the bismuth subsalicylates, but like I said, there's some concerns there. And as far as their, salicylate toxicity, and if the pediatric patient, or if they're pregnant, or if they're already taking aspirin. Another advantage of the loperamide is it is usually more effective anti-motility agent than Pepto, than the bismuth subsalicylate. However, the bismuth subsalicylate, the Pepto, may be good to use when you cannot use loperamide. So, for example, if a patient has fever or dysentery, then that may be an instance where you use the bismuth subsalicylate. And then again, please monitor the dose, especially pregnant women and especially pediatrics. And then you always want to be mindful of that salicylate toxicity. So if they're taking aspirin or other aspirin-containing products or other things that are there's some other medications you remember from the GI module that are chemically similar to aspirin or have the salicylate structure in them. You have to be mindful and be cautious with those. Oh, so just real quick before I go over that. So with the symptomatic therapy, hopefully it's clear. For most of your patients, you're going to go with the loperamide first line. Excuse me. Sorry about that. I have allergies or something today. I can't stop coughing. I'm trying to not cough on you guys. But just as an overview, just to recap, for symptomatic therapy, anti-motility agents, first line is going to be the loperamide, unless they cannot take it. For example, if they have a high fever or if they have bloody stools, then you're going to want to go with the bismuth subsalicylate. And then when you're comparing the loperamide to the Lamotil or the difenoxylate, you're going to want to, loperamide is considered, first line compared to the difenoxylate because of its, central acting opioid, and you have to worry about the anticholinergic adverse effects of that other one. So hopefully that's all clear there. Because I definitely, for testing purposes, want you guys to know, first line, second line, third line even, and then the rationale and when to use things, when to avoid things, when to be careful with things. So bismuth subsalicylate. What population should you be more careful with them? What type of toxicity do you have to be worried about with bismuth subsalicylate? So hopefully those are all clear with this lecture. So a lot of this lecture, and why I'm like kind of hesitating throughout this lecture, a lot of this lecture is FYI, and it's just just hopefully going to help you guys with ICM and kind of give you guys a great picture. The other thing too from this presentation, make sure that you look at those oral replacement therapies and those commercially available products. Don't worry about memorizing those, but just know that you do need to replace your electrolytes, fluids. Hydration is really important, and oral hydration is very important. But for this testing purposes, for this presentation, please focus on the drugs as usual for my course. Probiotics here too, they can be beneficial. I mentioned the yogurt has probiotics in them, or and again, if they're live active cultures. So I'm sorry, I can't catch a break. I'm drinking hot tea and stuff too, and I'm just like just trying to get through it. Sorry, I'm trying not to cough on you guys. I promise. I know it's super annoying, all the coughing. But yeah, so this is actually they haven't shown much evidence as far as it being valuable taking the same time of antibiotics. It can't hurt though, or rather, it doesn't. A good probiotic live active cultures of these beneficial bacteria do help the GI health overall. So they do help your gut flora. But so it's really going to be up to the patient as far as, if they insist on taking it, it can't hurt. And then just a little shameless plug here. No, I'm always, when patients come to me and ask me in the pharmacy about the best probiotics they can get, I try to encourage them to get it from their diet, from their food. So fermented foods, things like yogurt. And you look all over the world, all the, traditional cultures, all, US, Europe, Asia, Africa, all over the place. They all have a history and a tradition of fermented foods. So I always encourage the patient to go, whatever fermented foods are part of your culture, part of your heritage, foods you like. And then if not, they're all the grocery stores and stuff too. So, and this isn't on the test. It's just something I like to tell students about. And speaking of too, again, shameless kind of plug here with, I like this guy, Sandor Katz. He does a lot with fermentation and stuff, and he has a book called Wild Fermentation. Not sponsored by him, not a friend of him. I'm trying to be his friend, but it won't reach. I'm DMing him like crazy. No, I'm kidding. I'm not internet stalking him or anything. But this is a good book too, that if you guys are interested in learning more about fermentation and the benefits of fermented food. Yeah, so again, not on the test, just something I wanted to tell you guys about and just kind of jam in there. This is just FYI. It's just something I'm interested in, and I think it's cool stuff, and I love fermented food. So, so anyways, not on the test. For the test, like I said, please focus on the medications. So as always, if anything I said about the medications wasn't clear or anything, if you have any questions, concerns, feedback, please email me. And thank you guys for your time and attention. Thank you guys for listening to me rant and rave about fermented foods and how great they are. Now, so anyways, you can also email me about fermented foods if you like, or tell me about your favorite fermented foods from your culture and stuff, and all the cool things that you guys do with fermentation at home or whatever. But anyways, okay, or you don't have to. Don't worry about it. All right, talk to you guys later. Have a good one. Bye.